Thank you very much, Dr. Lagunju. Good evening, everyone. I'm Kafilat Afolabi, and I will be taking this presentation topic today, which is MRI characterization of spinal cord tumors. All right. Okay, so I'll be taking this topic following these learning objectives, which includes how to classify spinal cord tumors, recognizing imaging patterns. At the end of this lecture, we should be able to state the differential diagnosis associated with each class of tumors. So like I said, these are the learning objectives, and I will be doing that using this outline. So as a way of introduction, the spinal cord is the main information pathway connecting the brain and the peripheral nervous system, and it transmits nerve signals from the motor cortex to the body, and also transmits afferent fibers from the sensory organs in the body to the brain. It extends from the corticomedullary junction. I would like to know if anyone can see my pointer, please.
Yes, we can.
Yes,
all right,
can.
thank you. So it extends from the corticomedullary junction up to the conus medullaris, which is usually at the level of L1, L2. Spinal cord tumors are rare, and many clinicians may be unfamiliar with the imaging characteristics. Sometimes these tumors are diagnosed after significant delay. They also pose diagnostic and management challenge, especially in sub-Saharan Africa, especially because of the heterogeneity of the spinal cord tumors. There are quite a lot of them with overlapping imaging features, as well as the lack of easy accessibility to magnetic resonance imaging in our environments. Epidemiology-wise, they account for about 2 to 3% of primary intraaxial tumors of the CNS, and there's a bimodal age distribution. It has been reported to frequently occur in the 3rd to 4th decade of life. A research study done by M.O. Udo and C.O. Udo in 2020 reported an incidence of 0.05 per 1,000 persons, and their peak incidence in that study was in the 6th decade. Badejo et al. As well reported in a pediatric population, reported age range between 3 to 18 years, and its peak incidence in 15 to 18 years. Similarly, Hadeolu et al. In 2015 reported highest incidence of spinal cord tumors in 20 to 29 age group. These tumors are frequently located in the thoracic cord, and most authors have reported an extradural location more than an intradural location overall. And in our environment, there's a slight female predilection from studies, most studies done across Africa. The mean duration of symptoms is usually about 6 to 12 months, and this shows that it's a chronic presentation. Most of these tumors are benign, with the metastatic lesions accounting for the greater percentage of the malignant group. So I'll briefly talk about some really relevant anatomy here before we dive into the imaging proper. So I have here annotated schematic diagram of the whole spine, and we can see this is a T2 weighted magnetic resonance image of the spine, and we can see that the cord is of intermediate intensity, and it's surrounded by T2 hyper-intense CSF. A magnified view here brings to view some of the relations of the cord. The cord sits in the thicker sac, and most anterior relation of the of the thicker sac is the posterior longitudinal ligament. Posterior relation of the thicker sac, we can see this blue arrow is pointing to an hypointense area, which is the ligamentum flavum. Intimately related to it is this T2 hyperintensity, which is the epidural fat. You should note that fats appear both hyperintense, both on T1 and T2 weighted MRI. So we can see the bony processes here, which are the spinous processes, fat in between as well. And we can see this area of low signal intensity, which is the interspinous ligament between the spinous processes. We see a magnified view at the level of conus medullaris here, and the originating, the cauda equina originating from the conus. So I have an axial T1 weighted magnetic resonance image here. And what I want to highlight here is the relationship of the white matter to the gray matter in the cord. Unlike the brain, see this area of hyperintensity, which is central, forming this H shape, is the gray matter, and is surrounded by this area of intermediate intensity, which is the white matter. So the next slide here, what I really want to focus on is the neural foramen. I have a schematic diagram here, say of an axial section at the level of L4, L5, so this is the lumbar spine, and axial T2 weighted magnetic resonance image as well, and sagittal T2 is actually a foraminal view, which is a parasagittal section. So what I really want to highlight here is the neural foramina, which is the region within this pink circle. It's also correlated with this, is purple. So purple rather, it's not pink. So we see these, the neural foramina are located below the pedicle, bounded by the pedicle of adjacent vertebrae bilaterally. And we can see these red arrows at every level. They are pointing to the exiting nerve roots, which is corresponding to the vertebrae at that level. So the exiting nerve root is usually surrounded by hyperintense fat, and we can see that the neural foramina, this P is the pedicle. We can see that the superior and inferior relations are the pedicles, and also intimately related posteriorly is the superior articular facet of the vertebra below, and inferior articular facet process rather of the vertebra above. VB is vertebral body, which is the anterior most relation. So we can see this neural foramina, the exiting nerve root, and the surrounding fat is giving this keyhole appearance. This appearance is very important because we have tumor traversing the neural foramen. As we'll see later, we'll understand that this anatomy will become distorted. So these are also schematic diagram of the transverse section of the cord, which highlights different parts of both the gray and the white matter. You can see the central gray matter, which has a dorsal horn and the ventral horn, and the surrounding white matter tracts, which are labeled here. So why this is important is that when we are characterizing spinal cord tumors, we realize that the area of the cord that is affected, which will also dictate the tracts and columns involved, could be a pointer to, the symptoms the patient presents with could be a pointer to possible location of the tumors. So classifying spinal cord tumors, they are classified as extradural, intradural, extramedullary, or intramedullary. So I have a schematic diagram here to denote what these are. And this pitch area is the cord, and the thin black line is the dura. So for a lesion to be extradura, that means it's outside of the dura. And you see such a lesion will form an obtuse angle with the cord itself with compression of the adjacent CSF space. An intradural lesion means that this lesion is within the thicker sac, intradural extramedullary. It means that the lesion is within the thicker sac. That's where the thicker sac is a space that contains both the cord and the CSF. So you see that the dura appears intact, but not necessarily in all cases if there's a tumor. And we can see that the lesion is also compressing on the related spinal cord. For the intramedullary class, it means that the tumor is within the substance of the spinal cord itself. And we can see the fusiform enlargement in this schematic diagram, as well as obliteration of the surrounding CSF space, which is what we'll see in the real life images that we're going to discuss soon. So the clinical presentation vary from muscle weakness to pain to numbness, balance problems, loss of sensation, fatigue, disrupted sleep, seizures, or drowsiness, or even coma. Most authors reported that most patients have motor deficit at presentation, and some studies have even reported that almost all patients have motor deficits as at the time they are presenting. So what's the role of imaging? One is for prompt detection, accurate diagnosis, determination of optimal treatment option, which includes, but not limited to, determination of the surgical approach to use as well, and of course, follow-up. So the MRI protocol for evaluating spinal cord tumor includes an axial sagittal T1 and T2 weighted imaging, as well as T1 plus contrast, usually done with fat saturation to enable better characterization of lesion. Other sequences are used, it includes diffusion weighted imaging with corresponding ADC map, which can show lesions that show restricted diffusion, particularly important in discriminating malignant and some cystic tumors of the spine. Of note is the case of trying to discriminate between edemoid, arachnoid, and dermoid cysts that we are also familiar with in brain imaging. So this is an approach to characterize spinal cord tumors. First, history and clinical correlation with neurological deficits is very important. This is one aspect of radiology that you want to make sure that you get your history, including age, duration of symptoms, and any other associated clinical findings right before you properly characterize the tumor for more accurate diagnosis. Anatomical localization, very important. You want to, because the anatomical location of tumors could point to what's the exact diagnosis that is, be it if it's located in the anterior aspect of the cord, posterior, lateral. There are lesions that correspond to various anatomical location. Also, confirmation of sectional location, which have also, so anatomical localization and structure sectional location goes hand in hand, as well as the segmental length. We also want to know how many vertebral level the lesion spans, a short segments being spanning less than 3 vertebral levels, and long segments being spanning more than 3 vertebral levels. Of course, an enhancement pattern is very important because some of these lesions have a characteristic enhancement that has been reported for them, which helps to pull down, narrow down differential and prone to a particular diagnosis. Of the multiplicity of the lesion also matters, which also further helps to characterize. Like I said earlier, the spinal cord tumors are a heterogeneous group of tumors, which includes, for example, this epidural group includes tumors that are primarily osseous lesions, but extend into the spinal canal or involve the spinal cord. But of most common epidural spinal cord tumor are the primary spinal malignant lymphoma and metastatic spinal tumors. The less common ones are hemangioma, epidermoid cyst, arachnoid cyst, and these other osseous tumor from osteoid osteoma and Ewing sarcoma. They are primarily bone tumor, propensity to extend into the thicker sac or involve the cord. So I'm going to be talking about the most common ones because time is not our friend, so we can't possibly take them one after the other. So, but it's very important when you have an epidural, you are evaluating an epidural spinal cord tumor, top on the list of your differential should be either a malignant lymphoma or a metastatic tumor. So this is a confirmed case of lymphoma, but before we go to that, how do we know that a lesion is in the epidural space? Remember our anatomy the other time? That was why we did anatomy. So one of the imaging findings in localizing an epidural tumor is effacement of the epidural fat. Remember in our anatomy, see this hyper intense area is epidural fat. We can see the yellow arrow is pointing at the lesion. We can see that there is effacement of the epidural fat at levels involved that these lesions involve until distally when we begin to see the epidural fat again. This is particularly very obvious because on my screen here, I have from A to D, magnetic resonance image of the spine, sagittal T1, T1 plus contrast, T2, and T2 fat sat plus contrast. So T1 weighted sequences are always very useful for delineating anatomy. And we can see that our epidural fat and the effacement stands out on T1. So from one, we have seen one of the signs of an epidural lesion. The other sign is if we look at the cord proximal to the level of the lesion where the yellow arrow is, we can see, like we discussed in the anatomy, that the cord is surrounded by CSF. At the level of the lesion, we see that the CSF space is compressed and obliterated. And we can see that because this lesion is located posteriorly, we can see that this lesion now compresses the cord anteriorly. So the key three features you should look out for when you are trying to localize an epidural lesion is one, effacement of epidural fat, compression of CSF space on the side of the lesion, and compression of the spinal. Depending on the size of the lesion may compress or not compress on the cord, but the other two findings are almost always constant. So going to an epidural lymphoma. We all know, just like lymphoma in every other part of the body, lymphomas are very cellular tumor, and we can see that the lesion, the tumor span is involving the thoracic cord and span about 4 vertebral segments. It is iso-intense to the cord on T1, and on T2 weighted, on T1 weighted plus contrast, we can see this intense homogeneous enhancement. On T2 weighted sequence as well, we see that there is iso-intense, and the fat sat T2 weighted plus contrast also shows enhancements of the tumor as well as marrow enhancement. So these findings shows that this lesion is cellular, is enhancing, and there's affectation of the adjacent vertebral body, which is something that is classical for an epidural lymphoma. The close differential of this is epidural metastatic lesion. Again, the findings of epidural lesion is present here. We can see the interruption of the epidural fat at this lesion, at the level of this lesion, which is closely related to the spinous process of T4. You can see that there is obliteration of the CSS space adjacent to the lesion, but the cord appears not to be compressed in this case. In addition, we can see diffuse marrow involvement in this particular case, because normally the vertebral bodies are supposed to be hyper intense, especially in adults, the yellow marrow. We see diffuse infiltration of the bones in a malignant metastatic spinal cord tumor as well. We can see that it almost looks like the lymphoma and the metastasis have the same imaging feature, but one of the discriminating features is that the lymphoma will usually affect the vertebral body at the level in which you are seeing the lesion, while a metastatic tumor may affect, or usually will affect vertebral bodies even outside of the levels you are seeing the lesion. You can see this lesion is only spanning one vertebral segment, and we have diffuse marrow infiltration and replacements, which is more in keeping with a metastasis. Additional finding is that a metastatic lesion is likely to cause wedge compression or fracture of the vertebral bodies, while a lymphoma does not usually do that. So that's how to discriminate between them. So I'll go to the next group, which is the intradural extramedullary lesions. And again, we have the common ones and the less common ones. The most common of these groups, which make about 70 to 90% of this group, depending on the environment, includes meningioma, schwannoma, and neurofibroma. The others are solitary fibrous tumor, dermoid, and epidermoid cysts. Then in the metastatic group, we have the leptomeningeal metastasis. So we're going to talk about how to discriminate. Since common things occur commonly, we're going to talk about how to discriminate between the common ones. Okay, so it is important to note at this point that intradural and intradural extramedullary lesions and the intramedullary lesions are often confused as regards anatomical localization. What I mean is that if a lesion is within the intradural and extramedullary, if it's big, one could think that it's actually intramedullary. So again, before we characterize any lesion, we must look for the imaging findings. So we have discussed the imaging findings we are supposed to look for the extradural, now the intradural. If you look at the images I have here, the images I have here are trying to get this off. Sorry. They are sagittal T2 weighted magnetic resonance image of the spine, sagittal T1 plus contrast, and MR myelograph. I've decided to put a lot of sagittal images in this presentation because it's easy to look at the spinal lesions on sagittal view. You can see the superior and inferior extent of the lesion. However, in real life practice, please do not characterize lesions on sagittal views alone. It is good practice to look at the axial section and correlate it with what we are seeing on the sagittal view, especially to discriminate properly the location of the tumor, which will then decide the differential or ultimately the diagnosis you're going to give to lesions. So it is good practice to also evaluate the lesion, not from the level of the lesion itself, but from, you always scroll and look at the lesion from a level that is normal, where you can see normal cord surrounding the CSF, unless of course, the lesion is involving the whole of the spinal canal and the cord. Otherwise, evaluation should always start above the level of the lesion and should continue distal to the level of the lesion. So I digress. So this is a case of intradural extramedullary meningioma, and we can see meningioma are usually, they are also cellular tumors. So on T2, they are of intermediate signal. Usually the signal of a meningioma matches the cord. Of course, because these don't read textbook, they could be slightly hypo-intense to the cord. So we see that on this sagittal T1 weighted from contrast plus contrast, we see homogeneous enhancement of this lesion with the dural tail. In brain imaging, we are familiar with dural tail, which is this extension, enhancement, thin extension towards along the dura, above and inferior to the lesion. So to be sure about this lesion is within, this looks quite straightforward, but for every case, it may not be so. So to be sure that a lesion is intradural and extramedullary, you look at the CSF surrounding the cord above the level of the lesion. You can see that the CSF space is almost of uniform caliber, but as we approach the lesion, we see that there is slight widening of the CSF space just superior to this lesion. And as we go distally to the lesion as well, we see that there's slight widening of the CSF space immediately distal to it. And as we go down, the caliber of the CSF space returns to normal. So this is a characteristic finding of an intradural extramedullary lesion, which confirms that whenever you see a widening CSF space, just proximal and distal to a lesion, it shows that it's within the thicker sac and it's intradural extramedullary. Note that the caliber of the cord is normal and at the level of the lesion is compressed anteriorly. Cord is not bigger than the upper part, but we can just see that this lesion is compressing on it. Another classical imaging finding is a CSF cleft surrounding the lesion. That is even more accurate in discriminating an intradural extramedullary lesion from an intramedullary lesion. Because if you see a CSF cleft, just like we see CSF clefts in some brain imaging, and it points us to some things. In the spine, if you look at the axial section, you see CSF clefts surrounding a lesion. It's likely to be intradural extramedullary. So from there, you kick off with your differentials. Okay, so my slide is hanging. It's probably my network. Be a bit of delay. So I'm able to move to the next slide. Okay, the slide is not moving. Okay, so apologies. Okay, so the slide is not moving from my end, so I believe it's not moving on my shared screen as well. Can anyone hear me, please?
Yes, we can.
Yes, we can.
Yes, we are hearing you. We are hearing you.
Move downward on the normal
board on your computer, then go back. When you get to the preferred particular slide, then you can go back to presentation mode. Do you get me? You can exit presentation mode, then you see the list of your slides on the side. Then you can select wherever you got into, then go back to presentation mode. Hello, Dr. Afolabi. Sorry for the break in transmission. I think we just lost her. Let's wait, give her a few minutes to be able to join back and continue.
I think I must have been disconnected. Hello, can anyone
Okay,
hear me?
we can hear you
Yes,
now. So
welcome back. We can hear you.
hear your screen back now.
Okay, so I was just talking to myself. I'm not sure of when I got disconnected. Andrew, could you let me know where you heard me last?
Yes, when you were talking about how your screen wasn't moving and was hanging.
All right, thank you. Can you see my screen now?
Yes, we can.
Have you seen this slide before?
Yes, this was where we were before you
Okay.
went off.
Apologies for this delay. So it appears my slide still not moving. All right. Thank you for your patience. So I move on to another set of differentials, which are the neurofibromas and schwannomas. So the neurofibromas, schwannomas, and meningiomas are the top differentials of intradural extramedullary lesion. So whenever you pick the imaging signs of these lesions, you must try to discriminate among the three. So I have here from my radiological right, parasagittal, actually a neuroforaminal parasagittal T1 with a magnetic resonance image plus contrast, and a midline sagittal T1 plus contrast as well on one half of my screen. So I'm going to talk about that first. And we can see that if you remember during when we were doing a quick review of the anatomy of the spine, if you remember how the keyhole appearance of the neuroforaminae were, you could see that in this lesion, we can hardly make them out. And we can see that parasagittally, there are multiple solid enhancing lesions spanning multi-level and extending into the neuroforamina, expanding them, of course, because we can see that these lesions are obviously bigger than the keyhole sign we talked about, where we see the exiting nerve surrounded by the beautiful fats. So, but we see all that is lost here, and it has been replaced with all these multiple masses, some of them are tending to coalesce. And in the same patient, we see again within the thecal sac, this ellipsoid lesion. We see them multiple at different level. This is a T1 weighted magnetic resonance image, and we can see that you see this hypo intensity just distal to this lesion appears to be like a cleft of CSF, which suggests that it's actually within the intradural space. On the other hand, I have sagittal T1 weighted, T2 weighted, and T1 plus contrast magnetic resonance image of the spine as well. And we can see that on the T1 weighted sequence, can hardly make out the lesion because it's almost iso-intense to the thoracic cord. Beautifully on the T2 weighted sequence, we see that this lesion sits within the thicker sac. It's actually closely related to the conus. So conus medullaris, because we have passed the level of the cord proper. But we'll see this lesion in the thicker sac on these two other views, which is the T2 and T1 plus contrast. What strikes us is that within this lesion, there is a T2 hyperintensity and T1 hyperintensity, which is in keeping with cysts. And this is a finding that suggests that this lesion is a schwannoma as against a neurofibroma. So oftentimes when there are intradural extramedullary neurofibromas or schwannomas, almost always neurofibromas will be multiple. 80% of schwannomas in the spine are solitary. A characteristic imaging finding in schwannoma is presence of cysts within the lesion, which will be hypointense on T1 and hyperintense on T2. As you can see, these hypointense, T1 hypointense and T2 hypointense area here. So we can ignore this incidental hemangioma, so it has nothing to do with the lesion. So that's how to differentiate a neurofibroma from a schwannoma. I haven't localized it to be an intradural extramedullary lesion. So another appearance of not just schwannoma, both schwannoma and neurofibroma actually, because sometimes it's actually difficult to discriminate between these two lesions. And that's why, again, clinical history presentations very important in our patients. Of course, we all know that neurofibromas are associated with neurofibromatosis 1. And so if you have a history of that or other clinical presentations in keeping with that, will be tilted towards neurofibroma other than schwannoma. So this dumbbell appearance of schwannoma that is depicted here can also be seen in neurofibroma as well. And this is when an intradural extramedullary lesion extends into the extradural space. So there's an extradural component of the lesion. And usually it goes through the neura foramina. If you remember our anatomy, the neura foramina is in these lesions. This lesion has extended from the intradural space to the extradural to form a paravertebral soft tissue. Of course, both lesions are enhancing, so you can use the enhancement pattern to differentiate them. Now I go to a summarized slide on these three common, most common group. So for population, it is a young patients, most likely neurofibroma, thinking neurofibroma, older patients, schwannoma. If it is older women, usually meningioma is commoner in women. It's often calcified. So if you see calcification, most likely meningioma. Meningioma classically shows a dura tail, so it's just like in the brain. So that's more in keeping. The three lesions are enhancing. Again, repetitions aids memory. If there's a cystic area within the lesion, likely to be schwannoma. Both neurofibroma and schwannoma can enlarge the neural foramen, can expand it, and they can cause all those, because they are slow-growing lesions, they can cause all those boning changes, including posterior scalloping, thinning of pedicles, and all of that spinal tumors can do. So, but we should note that meningioma generally brilliantly enhanced and is enhanced better than these two other. So again, like I said earlier, if there's a history or feature suggestive of neurofibromatosis, then neurofibroma is likely. So The next group I'm going to talk about, it's still intradural extramedullary, but the malignant differential, which is leptomeningeal metastasis. So on my radiological left here, I have a sagittal T1 weighted PAT-SAT imaging plus contrast, which the leptomeninges are tightly adherent to the cord. So usually when there's leptomeningeal metastasis, we see nodular enhancement intimately related to the cord as is demonstrated here. And using a fat saturation sequence helps to clearly bring this out. So a close differential of these will be drop metastasis, but drop metastasis will also enhance, but we'll see it as multiple discrete nodules at different level within the intradural space, within the thickle sac. So the next group I'm going to talk about are the intramedullary lesions, which are lesions are actually within the substance of the cord itself. This particular group have wider and more heterogeneous group of differentials as demyelinating disorders, inflammatory and infective conditions also affect the cord itself, in which case there will be intramedullary lesion as well. But before I dive into the tumors themselves, I want to state that again, history, clinical presentation, very important. And for tumors involving the cord generally, intramedullary lesion, they will generally expand the cord. They are usually associated with cyst formation or syrinx, and they usually hemorrhage. When you see those findings, you are safe to take your mind away from the demyelinating group, the infectious or inflammatory group, because you are most likely dealing with a tumor. So of these groups, the most common in the primary group and often benign are the ependymoma and astrocytoma. In fact, ependymoma and astrocytoma top list, while hemangioblastoma stays far behind. In the malignant variety, there could be metastasis from primary tumors in the body that goes into the cord itself. Other rare intramedullary lesions are cavernoma, ganglioma, paraganglioma, and malignant lymphoma, others. So the first step for every lesion, we have to recognize where the lesion is. An intramedullary lesion usually expand the cord. We have seen that the other groups that we have seen did not expand the cord substance itself. Because these lesions are within the cord, they expand the cord. And with cord expansion, we see that the adjacent CSF space is also narrowed. We see this lesion is spanning, the cystic component of these lesions spans from C2 level down here. So we can say that the relatively normal related CSF space above the level of the lesion, and see the CSF that surrounds the cord, or at the level of the lesion, we see that it's attenuated. So expansion of the cord, compressed CSF space adjacent to the level of the lesion, cystic components of the lesion, it could be intratumoral and it could be extratumoral. Intratumoral means that it's within the mass itself, and extratumoral is outside. So, and it could be the extratumoral cysts, could also be syrinx. These are features that are usually seen in most intramedullary tumor. Another thing is, you remember when we talk about characterization, these we have to also know the segments the lesion is affecting to discriminate between especially astrocytoma and ependymoma, because they are closely related in imaging findings, and it may be difficult to differentiate them. So usually you want to see if it's short segment, long segment. Short segment means spanning less than 3 vertebral bodies, and long segments greater than 3 vertebral body. So I don't know if anyone is already, maybe some people may already be thinking what this particular lesion is. Okay, so on my radiological left, this is a diffusion tensor imaging, which shows it's an imaging that is a form of diffusion weighted imaging, but it uses anisotropy to outline the tracts of the spinal cord. You can see that the tract of the spinal cord is both laterally here, and some studies have shown that DTI, so some authors had thought that DTI could be used to discriminate between astrocytoma and ependymoma. But unfortunately, even diffusion tensor imaging is unable to classically differentiate these because irrespective of what it shows on diffusion tensor imaging, it could still be one or the other. It's an assumption that because ependymoma are usually central and the fibers of the spinal cord itself may not be within or embedded in the tumor. So on DTI, they just go the tracts of the spinal cord. Why astrocytoma, which is a diffusely infiltrative lesion, usually was reported to involve the fibers of the spinal cord on DTI, but this is an evolving field, and there's promise that DTI could discriminate between ependymoma and astrocytoma. Okay, so usually an astrocytoma spans multiple levels, usually 4 to 7 vertebral body level. It's usually an ill-defined lesion within the cord. Of course, all lesions within the cord expands cord, and we can see this upper thoracic cord. The arrow is pointing at T1 iso-intense lesion expanding the cord, which appears hyper-intense. Okay, am I still audible?
Yes.
Yes, you are.
Which, okay, so which is and shows okay, thank you, which is hyper-intense on T2 and shows irregular patchy enhancements on post-contrast imaging. And this patchy enhancement pattern, the fact that astrocytomas are ill-defined, diffusely infiltrative, spans longer segments, are in favor when you want to choose a differential. And again, astrocytomas are commoner in children, while ependymomas are commoner in adults. So if you have that clinical history, it may be easy for you to put one or the other. Again, both of these lesions would show hemorrhage within the lesion, but ependymomas classically show hemorrhage. So here I have sagittal T1 weighted magnetic resonance imaging of the spine, as well as T2 weighted, and an axial T1 plus contrast, which shows a T1 hypointense upper cervical cord lesion, which is hyperintense on T2 and shows enhancement post-contrast administration. If you can see this T1 weighted sequence, we see this hyperintense area. From our MRI basics, we know that hyperintensity on MRI suggests, on T1 suggests hemorrhage. So this is an area of hemorrhage within this lesion. And we can also see on the T2 weighted image, we have an area of hypointensity. So for ependymoma, formation of hemorrhage and cyst formation are more extensive than what we see in astrocytoma. And it generally is a more well-defined lesions, like you can tell the upper from the lower margin, especially post-contrast administration. And these findings help to differentiate the two. So imagioblastoma is the third most common differential. And in terms of location, thoracic cord is most commonly affected. And we can see these images I have here are sagittal T1 weighted T2 and T1 plus contrast, which shows an intramedullary mass that is causing expansion of the cord, and there is also extensive cyst formation, which may represent syrinx, affecting almost the entirety of the cord. We see it well on this T2 fat sequence. And interestingly, you see this blue arrow is the lesion itself. So it's this small lesion causing the whole of the tremor. So an imagioblastoma classically is a nodular lesion, sometimes with cyst formation between it and numerous flow voids. So we see this yellow arrow pointing at flow voids adjacent the spinal cord, which are classical findings that you'll see in an imagioblastoma. And it also shows either extensive perilesional edema or extensive syrinx formation. So there could also be metastasis to the cord, and again, they may be well-defined lesions. They may be multiple. They may be solitary. So in this, and the enhancement pattern may vary. You could be patchy, you could be ill-defined, it could be homogeneous. Again, clinical history is very important. So if there's a patient with primary malignancy somewhere, and one of the considerations and the differential, especially if the person is in their 5th or 6th decade, because most studies have found that the spinal cord tumors in this particular age group are usually malignant based on reports from most authors. So we can see that this sagittal T1, T2, and T1 plus contrast MRI shows lesions that are almost isointense to the cord, save for the edema that we can see within the cord on T2 weighted sequence, and this particular one shows homogeneous enhancement. So one of the classical features of metastasis, just like we see in brain, is extensive surrounding perilesional edema that is usually more than what you expect for a small size lesion. So if you see something like that, you have to consider metastasis to the cord. Again, other features of metastasis may be present in other imaging done for other parts of the body, including in marrow involvement. So those are the findings to look out for to discriminate that. We are almost done. Thank you for staying with me so far. So I have a summarized table for the intramedullary tumors here for repetition. So you have ependymoma, usually adults greater than children, astrocytoma mostly in children, imagioblastoma usually adults. In terms of location, ependymoma are usually more central, while astrocytoma are likely to be eccentric. In terms of location, both astrocytoma and imagioblastoma are commonly located in the thoracic cord, while ependymoma involves more of the cervical cord. Ependymoma spans shorter vertebral levels, while astrocytoma is usually more infiltrating and spans more vertebral levels. One of the classical features seen in ependymoma is cap sign, which is formed from hemosiderin, classically seen on a T2 weighted image superior and inferior to the lesion. But please note that this cap sign is not mnemonic of ependymoma, as it can be seen in imagioblastoma and lesions like paraganglioma as well. 3 of them show enhancements of variable intensity, but classically astrocytoma is patchy. And in fact, because astrocytomas are usually very low-grade lesion, they may not show enhancement at all. So if you have a lesion that is not showing enhancement, then the cord in a child probably astrocytoma. Of course, there are associations. For ependymoma, it has been reported that is frequently associated with neurofibromatosis 2, especially in children. And astrocytoma studies are also showing that there's increased incidence with neurofibromatosis 1, while hemangioblastomas generally are associated with von Hippel-Lindau syndrome, which in about 1/3 of patients with hemangioblastoma, not just of the spinal, that statistic covers all hemangioblastoma. Such patients have, 1/3 of them have von Hippel-Lindau syndrome. Okay, so besides all these lesions that we talk about, which are extradural, intradural, extramedullary, and intramedullary, there are also lesions distal to the cord. And the most common in this group is myxopapillary ependymoma, and accounts for most of the tumors related to the conus, further equina, and finum terminale. It shares similar imaging feature with the ependymoma we have discussed earlier, and it's just that it's seen in older age group, in their 50s to 60s, and it hemorrhage much more than the classical ependymoma that is intramedullary. Other lesions are lipoma. Lipoma is, of the conus, is usually an incidental finding. It may or may not be related to tethered cord syndrome. This is one of the areas where our MRI sequences come into play. So when you do a fat suppression sequence, you expect a lipoma to fully suppress some fat suppression sequence. And with that, if a patient is asymptomatic, you may move on. Other lesions related to the cause are paraganglioma. Paragangliomas also share similar imaging findings with ependymoma. So they are close differential. Schwannoma and carcinomatosis, as we have talked about earlier, their imaging findings are still similar to what we discussed earlier. So we should just note that some of these lesions, when they are at the conus, they are likely to be these ones. In conclusion, MRI provides considerable information to diagnose spinal cord tumor. Understanding of the characteristic imaging findings is critical for accurate diagnosis and effective management. Thank you for staying this far.